Lot of presentations, so if you can all take your seat, that would be fantastic.
Okay, microphone.
All right, so our next presenter is Dr. Murilo Leie, who's an orthopaedic surgeon at Joondalup. He's going to update us on paediatric knee pathology. So thank you so much.
Thank you. All right. Good morning. Everyone can hear me? I think so. All right. Thank you, Wendy and Belinda, for organizing this, and congratulations for you guys to come in this morning in a day like today. I hope I can be somehow useful to solve kids' problems in the knee. All right. So essentially, I'm a knee surgeon at Joondalup. My rooms are in Joondalup, so those are the hospitals I work for. Honestly, I prefer Glengarry in Joondalup. All right, but yeah. And look, it's Murilo Leie, so that's how it's pronounced. So I do anything like for knee, problems, solve any knee problems essentially from age 6 to 99. I'm still not brave enough to do over 100. But on and on, yes, we see kids. And when we see in orthopedics kids, anyone skeletally mature, all right? The little ones don't really come to me, but those under 16, from their age 10 to 16, yes, that's when they end up having knee problems, and I can help, right? So let me see. This is the pointer. Green arrow, all right, cool. All right, so yeah, it's not often they come, with knee problems. They are very rare, knee problems in pediatric or skeletally mature patients. But it's getting more frequent, all right? And they are participating more in sports. And believe it or not, Australia is the leading nation in youth participation. And if you look at the list of sports they play, swimming number one, but this is a question of survival. But all the other sports are pivoting torsional sports, all right, that put the knee at risk, right? So that's why it's getting more and more common, all right? So how I would suggest you guys, when have a patient with knee problem, to think in your room. So think broadly, essentially, see their knee problem. There is a trauma, there is no trauma. So basically, with that, you can, reduce your number of potential diagnoses. So trauma, it's basically playing sports, trampoline, monkey bars, we all have kids. So non-traumatic ones, when it's unclear, vague symptoms, progressive, non-specific date of event. And in my practice, how I do a diagnosis, so I don't rely on scans, or I don't rely only on scans, on MRI, so look at the report. So I have many reports that were done wrong. So that's why I look myself to any MRI reports or knee X-ray, right, before the patients come. But essentially, to make a diagnosis, you need to think about, all right? So what are the potential diagnoses in, knee-related problems in kids? So traumatic ones, the top three: ACL, discoid meniscus, and osteochondritis dissecant of the knee. I will explain what it is. And the non-traumatic ones, you might see, I don't see those first two, growth pain and Osgood-Schlatter, sounds German. And he was. Usually don't come to my rooms, right? But infective conditions, yes, they are very common. There are some tumors in kids and some hip conditions as well that patients present initially with knee pain, all right? So I'm sure you all guys are aware of this, but worth to mention, yeah. So the conditions for you guys to request an MRI and it will be Medicare rebatable. So basically under 16, so if you suspect internal derangement, so request an MRI, okay? Ultrasound, it's limited, or the amount of information it's quick, but you can see if there is a fusion or not in the knee. That's it, all right. Anything else, we won't be able to see on MRI or on ultrasound, okay? So traumatic injuries, all right? So just ACL, all right? So we all know what ACL injury looks and feels like, some of us. Torsional sports, kids being tackled, all right? So usually there is a click, swelling straight away, or in hours after the injury. I don't know if you guys to examine your patient's knee, but Lachman test is the one that you apply some translation on the tibia. You will see that the knee is loose, all right? Some patients come with a locked knee, all right, so they can't really bend or extend to certain range of motion, so that can be a meniscal pathology associated too. Assessment always X-ray and MRI if you suspect there's anything internal in the joint, all right? And it can be from tibial spine avulsion. This is where the ACL is attached. In some kids, you will have, instead of the mid-substance tear, which is this one here, so the ligament is so strong that it pulls the bone off, right? So in those situations, we will try to repair, okay? So, but basically, a kid with ACL tear, if you eventually see in your room, so put in a brace, hinge knee brace, send to physios initially, just for the patient have some range of motion, some to avoid quads waist, all right? But the non-surgical ones are those really young, skeletally immature, under 13, isolated ACL injury, which is very rare, and those who, and if they develop instability after, so we need to treat surgically, right? So everyone over 13, I tend to operate, or those who develop instability, those with tibial spine avulsion, or associated meniscus and chondropathology. So this is even more important, right, than just an ACL. But that's the thing. So when we look at a report, an ACL tear, and sometimes we forget to look what is hidden, all right? So meniscal pathology and chondropathology are far more important than just an ACL. So in kids, so if you have an avulsion, we try to repair. Repair is always better than reconstruct, all right? So basically, there are all surgeries for ACL nowadays are through keyhole, right? So there are small implants that we can, so basically reattach the tibial spine and maintain the native ACL, but sometimes we can't, and you have to reconstruct, so we have to look at the growth plate and preserve the growth plate, so there is different sort of jigs we use to do the reconstruction kids, all right? What is important is counseling the parents, because unfortunately their kids are 5 times more likely to have a second ACL tear after the first, all right? Discoid meniscus, right? So meniscus, we all know, is a shocking absorbing cartilage. So that's the normal appearance of a meniscus. So that's the lateral, that's the medial. Looking from the top, the bottom here is the tibia. A discoid is when there is an abnormal development of the meniscus leading to a hypertrophic discoid shape. This is how a discoid meniscus look like. The patient will come to you complaining most of the time, 90% of the time, is on the outer side of the knee, all right, saying clicking, slapping, sometimes locking. So that's the feeling, all right? If they say that, so yeah, it's worth an MRI, okay? It's more common in Asians, but doesn't mean, it will be only in J. It's just could be anyone, all right? So always request an MRI to look at. That's how the MRI will show, right? So basically, on MRI, there's 3 or more 5mm sagittal images with the meniscal continuity. It's called bow-tie sign. So basically, it's a large, meniscus. It's abnormal, right? So we will treat with surgery only if there is a tear in the meniscus or if there is persistent symptoms. If they have no symptoms, no tear on MRI, just observe. No need to do anything, all right? But because surgery, what we do, so this is the abnormal discoid meniscus. So basically, it's clearly larger than it should. So basically, we trim the meniscus and try to reshape the meniscus to a more normal shape. Sometimes they are very unstable, and we need to use anchors to repair it, okay? So basically, those are the 2 options. That's why I do when they come to me. And sometimes we need to do both, all right? So it can be very tricky, but we try to preserve the meniscus, especially in kids, all right? So OCD, so you might have seen this, osteochondritis dissecans of the knee. So most of the time is on the medial femoral condyle. Basically, it's a pathologic lesion of the articular cartilage. It's a fail sort of the ossification process, all right? Usually that's the age you see, so 10 to 15. Most of the time is, as I say, medial femoral condyle. So they complain as well, pain, clicking, feeling like a loose body. Sometimes the knee can get really locked. So if that is the case, need an MRI straight away, okay? Ultrasound will not help, unfortunately. So that's what you can see. Of course, you start with X-ray. Sometimes you can see already on X-ray. So this is a normal shape of the femoral condyle. So that's like a shark bite. There's something missing there. Sometimes you see the fragment, all right? Sometimes the fragment is sitting there, all right? So this is the growth plate, all right? So those are the growth plate, which is normal. That's not growth plate. There's no growth plate in the epiphysis, right? So this is an OCD lesion. So in this one here was very unstable and come off, all right? So investigate, as I say, always MRI. So stable lesions are those who you don't see a cleft here in the cartilage, right? So you have increased signal underneath, all right, but the fragment is still there. And 50 to 75% of time, conservative management will fix the problem. But those unstable lesions you can see there, so you see there is a synovial fluid behind the fragment, that's not going to heal, all right? So this is surgery, all right? So for those stable ones, all right, restricted weight bearing, physiomuscular work, and you repeat an MRI in 3 to 6 months just to see if that lesion healed, and most of the time it will. Those who are unstable need surgery. So those are the options. So repair first. That's how I do. I always try to repair. I can't, do better than the native tissue. So I try to preserve at most. All right. So the options are using this implants. It's called smart nails. And then we basically arthroscopically we try to really fix the fragments. All right. Stabilize the fragments. All right. And hope that blood supply will allow healing, right? So, and most of the time happen, all right? Kids have a great ability to heal. So, but when we can't, or when that fails, so we have to reconstruct. And the second option is a procedure we do, it's called mosaicplasty. So basically, you harvest cartilage from all the bone and cartilage from other parts of the knee, all right? Which are less important, non-weight bearing, and you will insert in that area of defect. So that's how those little plugs look like, all right? And this is a procedure that is 20 years sort of studies showing 30 years good results of retaining the bone and cartilage. So that's the second option. So in the reconstruction ladder. So right, that's the traumatic one. So non-traumatic ones. So that's probably you might see, growth pain is something that's very old, right? So it was described in 1800. So still unclear. But basically those kids that have bilateral lower extremity pain, most of the time is lower limb bilaterally, night or evening and last minutes, all right? So that's what the growth pain sort of is being described. So there are many theories regarding. How can I go back? All right. Regarding muscular, bone fatigue, high level of activity, and some component of anxiety, especially parents. So that's being described. Right? But basically, its findings are all normal, systemically well, no swelling, no skin color change, no tenderness or palpation, X-ray is normal, or if eventually you request MRI, will be normal, but don't think, you don't need for this, all right? And that's what growth pain consists of, right? Any different finding should raise concern, and you request a blood test or X-ray and ultrasound, as I say, at least. Right? It's pretty benign, so treatment usually it goes away with time, and some over-the-counter meds, massage, sometimes addition of heat. Right? But this is what growth pain consists of. Right? The other condition, Osgood-Schlatter, right? So osteochondrosis is basically an inflammation of the tibial tubercle, right? Tibial tubercle, it's where the patellar tendon attaches, right? And in a skeletally mature patient, of course, you have a growth plate there. And this is an area of high stress, especially in those kids who play like a jumping sport, all right? Netball or basketball, footy, all right? So what happened, sometimes they come, you can see that proeminency there, it's tender on palpation, right? And that's why you look on X-ray, so you can have sometimes some fragmentation of the tibial tubercle, right? It's, as I say, tender, and MRI usually is not required, right? So if it's tender on palpation, have a lump, and the X-ray shows that. That's Osgood Chilateral, and it's pretty benign as well. It's managed with symptomatics, NSAIDs, activity modification, and physiotherapy most of the time. Right? So I don't need to see this because there's no really surgery for this, but this is something you might find in your day-to-day, and it's pretty benign, and I'm sure you guys will deal very well with that. So, but anytime, I'm happy to give any advice if you need, of course. Osteomyelitis and infection, so they do happen, all right? So always need to be a differential diagnosis in kids, and we all know why. So because, yes, that's how they are. So always keep that in the back of your mind, all right? So it can be infection, all right? So, so if a kid that systemically unwell or have temperature or recent infection or any raise in inflammatory markers, all right? So infection, needs to be number one sort of potential diagnosis here. So they can present with leg pain, tenderness, limping, effusion, irritable joint. So try to passively mobilize the joint if they react. So that's it's not a good sign. But if you get this in your rooms, all right, so send it straight away to ED, all right, because could be osteomyelitis, could be septic arthritis. Osteomyelitis tends to be more benign when well treated acutely, but septic arthritis not, all right? So if you suspect, send it straight away, okay? And that's why in kids, so osteomyelitis is usually at the metaphyseal, the proximal part of the tibia, and the knee itself, that metaphyseal region, it's intra-articular, right? So that's the knee capsule, right? So if you have osteomyelitis here, sometimes can breach the cortex and go to the joint, all right? And then becomes septic arthritis, all right? In some ages, also there were some vessels that can cross the physis and go directly to the joint. So that's why those two diagnoses, they usually walk together and they can be related, all right? So osteomyelitis will be, in hospital treatment, as you know. IV ox is the protocols, 4 to 6 weeks. But septic arthritis, we always need to aspirate this. We're going to do this on ED, and we're going to do arthroscopic washout straight away after if you have a suspicious fluid from the aspiration, right? So this is ASAP. And that's what we will find sometimes. You have sometimes synovitis and even pus inside the joint. So that's really important to send it straight away, okay? The other thing I want to say, so yes, unfortunately, I know you don't see this most of the time in your rooms, but unfortunately tumors are common in kids, especially the good ones, the benign ones, right? So that's what unicameral bone cyst looks like. It's very expensive, and they can report, pain in the knee. There was the osteoma osteoide, which is one in the cortex here, but there are nasty ones, could be osteosarcoma. So that's why any atypical aggressive appearance in X-ray, concern raised by radiologists, or you're just not comfortable to assume that is a unicameral bone cyst, it's a benign cyst, lesion, call, discuss the case, PCH, any ortho consultant registrar will be more than happy to take the patient straight away, or even give advice looking at the X-ray and say, this is a simple bone cyst, no need of any further intervention, okay? Cool. And just the last topic, so I want to say, so there are knee problems, there are not in the knee, all right? So sometimes patients come to you and you examine the knee, the normal X-ray, normal examination, normal MRI, and they still complaining of knee pain, all right? So look at the hips, all right? So frequently problems in the hip can have radiated pain down to the knee. Just check the hips, examine the hip. If there's some irritability or some stiffness, just get an X-ray. So you can be from slipped epiphysis to Pertus disease, all right? So in these also need to be addressed, this urgently, semi-urgently. So always check the hips, just examine the hips, all right? So summary, I just want you guys to take some message home. So don't treat every knee as a growth pain, all right? Don't think tumors do not exist in kids. They do. They're very rare, but they do exist. Think broadly, trauma, no trauma. Remember to check the hips, as I just said. X-ray and ultrasound normal if you suspect of any internal problem, locking, clicking, request an MRI. And remember the most common problems, right? So on trauma side, ACL, discoid, meniscus, osteochondritis dissecant, or growth pain, osgood-Schlatter, infection, eventually tumors, and hip problems as well, okay? That's my website. If you want to be competitive again, come to see me. So if you're bored in a Friday night, you want to listen to some podcasts of ACL, you can listen to as well and get some CPD points for you. But if you want to just contact me for any question or any patient or advice, so that's my mobile. Always happy to take calls, all right? And discuss anything you like to. And thank you very much for coming here this morning and paying attention. Thank you.
Murilo. No, unusual. Oh, yes, no.
My son does a lot of sport, and I queried him last night about how much warm-up does he actually do, and then I went onto that website that was on the pre-reading, and there's quite extensive information about warming up before footy, especially over 12. How much is that actually part of training of coaches?
Yeah, so basically, time exactly, probably I don't have the answer, 30 minutes, 1 hour, right? But there is even a protocol that's called FIFA 11. I'm not sure if you're familiar, but it's a protocol. It's made for soccer players, but you can, use for any sports, right? Competitive sport. So basically, it's a warm-up protocol, all right, that is done prior to prevent injury, all right? So definitely that's been proven that warming up and follow, those protocols reduce the risk to have an injury in sport, all right? In young athletes, an ACL injury can be catastrophic, all right? So it can be like a career changing for someone that is, number one footy player and then have an early ACL. But definitely warming up. Look, I wouldn't say what time frame, how long they should, but they definitely should do. Every competitive sport player, your son, should do at least half an hour of warming up before jumping the field, right? So that prevent injuries. Thank you.
With regards to Osgood-Schlatter,
yep.
How long would you like to keep the non-steroidals? Would you say no more sport? And how would you communicate that to the child and the parents who are keen on sport? And I find that very hard to be communicated most of the times.
Yeah, it's a very hard when you have to tell them, or change your sport, all right? So it's hard for me to say, all right? But I try to, all right, so let's alternate days, you do this, and then the other days you rest. If they're in acute phase of Osgood-Schlatter, so they have to rest at least a couple of weeks, all right? So otherwise, most of that is related to activity, right? So basically, if they continue on, can become a chronic problem. Sometimes if they have that amount of ossification, we need to take it out, right? But a couple of weeks at least. But anti-inflammatories alone would not be enough, right? So they have to understand. And I know it's your job, it's my job to go in parents' heads and say, stop them for a couple of weeks. And that's really hard, it takes a lot of time for them to slow down. But this is a condition that is highly related to the sport they play, all right? But a couple of weeks, there are other options as well, treatment. So physios usually do that, shockwave therapy. I'm not sure if you guys do this in your practice, probably not, but usually it's physio and sport physicians as well are happy to take those patients on board. Sports physicians can do as well from infrared and shockwave therapy, right? So this is another adjuvant therapy that's been proven to be helpful, right? But essentially, if they can slow down for a couple of weeks, that would be probably reduce the symptoms, right? And usually we don't recommend injection of steroid around that area because it weakens the tendon, and sometimes they can have a patella tendon disruption, right? So I don't recommend that. So
I just wanted to ask about clicking of the knees.
Yeah.
So I have patients that come who have, clicking of the knees, but there's no pain. It doesn't really impact on their everyday function. Is this a variation of normal, or is this like the first sign of them developing something that might need to be dealt with?
look, clicking in the knee, especially something that is ongoing or something that new, all right, and persistent, all right, it's worth to have a look, all right. It can be a loose body. It could be osteochondritis dissecans, all right. It could be a piece of the femur that come off. It doesn't hurt now, but it might cause further damage if you leave it, all right. So basically, I would treat, investigate more if they have a new clicking or persisting clicking. And as I say, if you write down the suspected internal derangement, OCD, discoid meniscus, MRI, okay? So there's no harm, there's no radiation, and now is for those conditions are, rebatable, so it's worth the request.
All right, wonderful.
All right, thank you.
Thank you so very much.
Thanks so much for your time. Thank you.
All right, so we now welcome Dr. Paul Sander to give us a good run through on managing the febrile child. Obviously something we see often, but something that still needs a lot of careful thought, and a refresher on thinking a little bit outside the box with that today as well. Paul's a very experienced educator in the paediatric space, and he works at PCH through the emergency department. Thank you. Thanks, Paul.
Just going to put that there. Hello, everybody. Can you hear me up the back? No? All right. Can I just use this one? Yeah, I'm getting a thumbs up. Cool. All right. I'm Paul. Thanks for having me. Good on you for turning up on a weekend. And good on you for putting on a day like this. That's really cool. Give me some buttons. This guy? Green arrow. And? Green arrow. Big guy. Okay, cool. Thanks, Wendy. Good. Let's talk about fever. We've got heaps of time. All right. We've got heaps of time. So we're going to talk about anything you want to do with fever. I've got some things I'm happy to talk to you about, but if you've got questions and comments along the way or challenges along the way, let's just, we'll have a chat and we'll figure it out together. We're going to talk about what the stress is all about with fever, when to be worried, when to investigate, and when to refer. There's a few familiar faces. So I'm going to talk to you about the Australasian PEDS way. This is the way most of us practice fever management in kids in Australia, New Zealand, and mostly all over the world now. It's the way we do it at PCH ED, where I mainly work. PEDS ED, I'm just checking that none of my colleagues are in the audience, but mostly it's a bit of an evidence-free zone. I love that because it means you can just play, and it also means we can't be, we have to be a bit kind to our colleagues when they're doing it a bit differently, because there's no really great evidence around this, but there's an agreed way that we all seem to do things. So we'll talk about that, but there are different ways of doing things. Take away what resonates with you, and I want challenges and questions as we go, all right? There will be a lot I'm going to cover. I'll come back to that in a sec. And, love that. That's the next slide. Thank you. I promise you're not a plant. So there'll be a lot, and you'll remember some. You'll write some stuff down. If you don't want any of the rest of it, you just leave it behind. It's fine. We'll have lunch. So this is what I say to families, and I know a lot of you are saying this to families as well. Fever is great. Fever is a sign of a healthy immune system. I love fever. And this is something I read recently, which I liked. It's not something that an infection does to our body. It's something our body does to the infection. That's it. I'm not going to go through any cytokine pathways that none of us remember. This was your question, right? Yeah, you're welcome. So auxiliary temps, it's a few bucks from the chemist, or you nick it free when you've had a baby from the maternity ward, and you stick it under the next to the axillary artery. That's for babies. You can do that as long as you want. You can stick it under the tongue for older kids as well. That's reliable. Tympanic membranes for thermometers for older kids is also reliable. Skin temperature is unreliable in terms of scientifically checking fever. It's really reliable in taking people's money when they buy it from chemists. But, if people do it, I don't stand in their way. But I say if you want a little bit more of a scientific one, it's under the arm or in the ear. We'll take a moment to talk about tactile temperature by parents. Maybe if I look here, then I won't have my back to you. These guys, these guys a few years ago did a systematic review and meta-analysis on parents reporting of their kids' fever. I'm sure you guys do. I'm used to a bit more of a smaller room, but give me a nod if they'll turn up and they'll say they've been hot, they're febrile, and they're not. They're smiling at you. Thank you for all those nods. That helps. So these guys produced a paper, 3,400 kids, where they checked if the parents' reporting was accurate. Interestingly, they're not so accurate on febrile kids, but they're reasonably accurate on afebrile kids. So if a parent thinks their kid is normal, it feels normal, they probably are. If they feel hot, they probably are, but it doesn't mean they've got a temperature, right? These guys this was in GP practices in the UK. So, and only a few years ago, it was, and they actually compared, they did a bit more of a scientific study where they asked the parent and they did a temperature check. And so I've got to read this right. So of the group of parents, so the parents who said their kid had a fever, only a quarter of them did. Of the ones where the parents said they don't have a fever, 99% of them didn't. So I find that slightly helpful. What's more important to us is that we have to manage the discord, right? So we have to shine a light on the fact that we're both right? So yes, they did feel hot, and yes, they don't have a fever now. It's the same as the ones that come into you and say they haven't had anything to eat or drink for 3 days, and you're more worried that they're running around so much they're going to give themselves a head injury at the end of your bed, So that's fine. They haven't had anything to eat or drink for a few days, but the good news is they're still hydrated because we're designed pretty well and we can survive for a couple of days without drinking much. So we do a lot of discord management in paediatrics, and I know you guys do a lot as well. So this is I find that somewhat helpful because you can say it's okay, they did feel hot, but they're not now, and that's great. All right. So when I do a bit of teaching, but it's usually in small classrooms, and I just have a whiteboard. So when Wendy Belinda said, come and give a talk on fever, I was like, sure, give me a whiteboard. And they said, the ones up the back might not be able to see. And I said, what do you mean the ones up the back? So, but nonetheless, we'll give it a go. Just shout out for me. Give me a cause of fever. Tell me. UTI. Yep. Pneumonia. Virus. You're not allowed to say one that's already been said. Meningitis, skin infection. Which one? Malignancy, yep. Kawasaki, good one. Everyone loves a good Kawasaki. Vaccinations, who said that? Yeah, controversial, yeah, but yes, sure, why not? Yeah. Did someone say autoimmune? Yeah, good, yeah, and about the 3,000 things which fall into that category. Malaria, sure. Sure, return traveller, yeah, why not? Allergic reaction with fever, ooh. Yeah, why not? Yeah, all right. Dehydration to fever, maybe dehydrated because they've got a virus. Yeah, okay, fine, yeah, fever. They were overdressed? Sure. Yeah, sure. All right, fine. We're scraping the bottom of the barrel, aren't we? Appendicitis? Oh, yeah, the kid's fine, but the thermometer's got the fever. Yeah, fine. Yeah, who knows where they put it? Gastro, yep. Environmental, yes. Medications. Who said that? Which one? No, you don't want to own up. Yeah, I don't know either. We'll think about that one. Say again? Otitis media, yeah. Who's that? April arms. Yeah, I had April, yep. All right. It was a reasonable list, but pretend we'd just written that up on a whiteboard. Malignant hypothermia. Yeah, right. Yeah. I hope they're not walking into your office with it. Good. All right. My point is there's a lot of things, right? So I usually group them into about 3 different things. Oh, can I go back? I can. So infections, we all know, viral, bacterial, parasitic, fungal. It's drilled into us in med school, but these days, except for your malaria, mostly it's going to be viral or bacterial. When we say viral, it's all of the viruses, and we know we're teeming with them at the moment in the community. Bacterial infections, they can hide wherever they hide, right? In the bladder, in the bones, in the joints, in the skin, in the brain, and CSF sometimes, a lot of the time in the respiratory system, ENT. Fine. All the autoinflammatory type ones, yes, Kawasaki you might see. Usually they're sick enough to come to us by then, or if not, you're certainly sending them to us. A bit of pericarditis maybe, rheumatic fever in the indigenous population, and we'll talk about that. The periodic fever syndromes are a little odd. And then PIMS, TS, and MIS-C, all those post-COVID syndromes that everyone got excited about a few years ago, which was very similar to Kawasaki. Happy to talk more about that, but we're not seeing it so much anymore. And then the big one someone said down here, the neoplastic syndromes, which present with fever. Cool. Okay, so what's all the stress about? So we see 20%, in some studies up to 25% of our kids present with fever, right? These guys did an Australian survey of over 12,000 parents. Only 42% knew that 38 degrees and over was a fever. They were all packing it. They were really concerned in the community that fever is going to turn into seizures, that's going to turn into dehydration, serious illness, and brain damage. So that's what they're stressed about. Interestingly, only 65% of them are doing kind of evidence-based Panadol and Nurofen, and not stripping the kids off and sticking in front of a fan and all that sort of stuff. But there's a lot of stress out there. Yeah, I was interested. I mean, some of them are worried about all sorts of horrible stuff. This is data from PCHED from the last few years. We're seeing, so this was all the kids who presented with the word fever or febrile in triage. And that's not including the ones who rock up with belly pain and fever, or wheezing and fever, or whatever. So there's probably, last year, it's going up and up and up. Last year was 27,500. So we're probably talking about 30,000 kids a year to PCHED alone. And you think about the hundreds of thousands of kids, GPs and peripheral hospitals are seeing every year with fever. So there's it stresses us because we're seeing a lot of it. Our just discharge rate is 73% of just these kids. So we're sending home 50, 60, 70 kids a day from PCHED with fever. And granted, some of them do get a test or something, investigation, and we'll talk about that. But it's just reassuring that most of them are fine. And a shout out to Brendan Tarr, he's our data guru who gave me this, who prepared that for me. Probably have to talk about this, sorry. What's all the stress about? Media. Oops, come back to that guy. Yep, 2021, there's the sepsis case in PCHED, the more recent case with the sepsis at Joondalup that you've heard of in the news. Everywhere, if you Google sepsis, death, child, Australia, you'll just see it all over the country all the time. So there is a lot of stress. And Ian Everett, who some of you may remember, he was a paediatrician in Perth who was part of the original PEDS emergency movement and specialty. He used to say that sepsis isn't finding a needle in a haystack, it's finding the piece of hay in the haystack that in a few days will become sepsis, right? So if it feels difficult when we look at fever and think about sepsis, it's because it is. Yeah, and if you're feeling like everybody's a bit shitting themselves about it, it's because they are. It's really hard. Almost all sepsis had a virus a few days ago, and almost all the viruses don't turn into sepsis. Yeah, what a really frustrating game. Yeah, so, yeah, it is. Anyway, I just thought we'd share that moment together. Good. So that's just a quick, what is fever, what causes it, and why is there so much stress about it? And now what we're going to talk about, we'll go through a couple of different age groups. We'll spend a bit of time talking about fever without focus and the different types. We'll talk about UTI, pneumonia, and otitis media. In terms of bacterial infections, we'll talk about when to investigate and treat, and we'll talk about when to refer. So we're going to bounce around a little bit. But at this point, does anyone have any questions, comments, challenges? How many swear words am I allowed in an hour? I think I'm up to 3. 5. Oh, okay. Oh, yeah, okay. Should have banked a couple. All right, neonates. So for you guys, if you're seeing a neonate, you will often see neonates, I know, and the parents, 2-week-old, they felt hot. And you've got to figure out what to do with this thing. And nobody trusts neonates, right? We don't trust neonates. Some of the things which will make it a little bit easier is that history, specifically around Group B strep. So you're asking mum, well, you could be asking dad, depends who brings the baby in, but you're asking about the high vaginal swab. Was there Group B strep isolated on the swab? Was it treated? Did it need to be treated? Was there maternal fever during labour? That's a big one. They might not remember APGAR scores, but they might remember, did the baby come out and scream straight away? Did the baby stay right next to mum? Was it given to her straight after birth? All that sort of stuff. Did baby get blood tests and antibiotics? That's often a good one. They go, oh yeah, they did do daily blood tests for a few days. That usually means someone was worried about sugar or CRPs. And the big causative bacteria for neonates is Group B strep, E. coli, and to a lesser extent Listeria, which is why nobody can have sushi and soft cheese anymore. Obviously, any neonates you're worried about fever, it's pretty easy. You're referring to us, or your local ED. You're giving them a heads up that they're probably going to have some invasive tests. Please give them a heads up that if they're coming in with a neonate query fever or a neonate definite fever, they're getting heaps of tests. It's not going to be heaps of fun, and they're probably staying overnight for at least a night or 2. So it's really nice if you've got that as a heads up, and they can maybe go home if the baby looks well enough, pack a bag, or they can send someone to bring a bag or something like that, right? Because we're going to do we're going to collect a urine, we're going to do a blood test, we're going to do a drip. That's going to be tricky. We might have to try twice, and we're going to do a lumbar puncture. If we're really and a biofire, because everyone loves biofires these days, like what do you call it? Respiratory swab. Biofire? Do you call it that as well? No, a respiratory swab. The PCRs. Give me a nod. Are we on the same? Yeah, fine. All right. Fine. So that's neonates. It's fairly easy, and they come to us and we get treated. All right. So it's infants and toddlers, slightly older. That you differentiate a little bit. Is this a toddler with a fever and a focus, or a fever without a focus? And we'll talk about fever no focus a bit later. If they're a fever with a focus, what you're trying to figure out is how unwell they are, right? So because there's a sick kid with a fever and a well kid with a fever. All of the kids I see will start with one decision box, sick or well. And I'm very boy ED brain now, and so rash, sick, well, well, not really. I mean, that's fine. I'm happy. You can do whatever you want with that one. And the same with fever. If they're well, happy-looking fever, we can spare some time to think about them, but they're going to be fine. All right. The duration of the fever is also something that we need to think about, and we'll talk about that. And we can ask about sick contacts and daycare. I'm still not quite sure what to do with the information. Do you all ask about sick contacts and daycare? Yeah, and you all blame. Yeah, like there's someone sick at home, they go to daycare. Oh yeah. But if there's no one sick at home and they don't go to daycare, it must be Woolies or Coles or yeah. So I love asking. Don't get me wrong, and we still pay out our juniors if they don't ask. But I'm still not sure what to do with the information. But it's great fun to ask. Older kids, adolescents, you treat them like adults. Like there's usually a source. They can tell you that their throat's sore. They can tell you that they've got a sore upper quadrant and they're feeling like crap and they've kissed people and they've got glandular fever or something like that, and or a cough and pneumonia. So that's generally less of an issue and certainly scares GPs and paediatricians much less. All right, so let's talk about fever of unknown origin. You might have heard it talked about as fever without source, fever of unknown origin, pyrexia of unknown origin, all the same thing. I'll probably use it a few different phrases, but this is what I mean. It means fever with no other symptom or sign. Okay, so we've just gone through all of those differentials before. What's still on our list, if you've got a kid in your clinic with a fever and no other sign. Let's say they're a toddler. Toddlers are the majority. A fever, no other signs or symptoms. What's still on your list of differentials? UTI? Yep. Tell me. Malignancy? Yep. Autoimmune? Yeah, maybe. Meningitis? Yeah, they probably have some kind of signs or symptoms. A virus? Yeah, thanks. Yeah, it's always a virus, right? Yeah, could just be a virus. Could be a joint, but usually you'll see that. There's a sign or a symptom there. There's not heaps, right? Yeah, because these are the ones which bother me. The ones with signs and symptoms generally, and there's some good papers that generally the community doctors are following the guidelines and they're adhering to guidelines on this because there are signs and symptoms and clues, and so you treat as you normally would. You'd send them home for a couple of days, they don't get better, you put them on some antibiotics, fine, whatever. But it's the ones without signs and symptoms that bother me. The other ones, if they're looking sick, you also know what to do with it because you send them in because they're sick. You know, if you're worried about sepsis, you send them to us. So they're usually less of a problem. Here's another question without a good answer, so you can't really be wrong. How long would you have a kid with fever and no other signs of symptoms before you want to do something about it? Got a 5 days? 7 days? I feel like I'm selling horses. Do I hear it? Yeah. Anything different to 5 to 7 days? 2 days. Yeah, you're right in there. Say again. Oh, how high is the fever, April? Yeah, good question. Wasn't a question, it was a statement. Depends on the fever. Yeah, we can be worried about number. The number is, families often ask you how high is too high. I usually say 42. Because we can agree on that, right? Yeah. If I say 40, they're like, oh. If I say 38, they're, oh. Yeah, 42 definitely. We can talk about 40 to 42. Everything less than that, I don't really care that much. 5 to 7 days is what I'm getting the majority. Let's go with that for now. And we want to ask about vaccinations, and we'll talk about vaccinations, but we do manage, and we probably should manage, febrile under and unvaccinated children differently to febrile vaccinated children, and there's a science why we do that, yeah. Yeah, good question. Is over 37.5 considered a low-grade fever? Sure. Yeah. Yeah. I mean, the hardest decisions in medicine don't make a difference, right? So maybe, yeah. I mean, over 38, I think we're all agreeing, is a fever. So you read somewhere that normal is 36.5 to 37.5. Some people say babies are slightly hotter. Yeah, I'm not sure. It bothers me. Yeah, but I like saying low-grade fever because then everybody agrees. Like under 38, oh, they've got a low-grade fever. Fine, yeah, everyone's more comfortable with that. Cool. All right. So you've got this fever of unknown origin. All right, so these are the kids with fever and no signs or symptoms. Then you've got kids who have prolonged fever. They might have RSV, influenza. They've got lots of symptoms, and you guys would be seeing this. It's really annoying. COVID was really annoying because it caused long fever with symptoms, right? Much more than the couple of days we're all used to, right? We're all used to 2 days of fever, the snots, the coughs, eventually a bit of the runs, and then this annoying cough and runny nose. But the fever goes away after the beginning, right? These days we're getting some viruses where the fever lasts a long time, even with the cough and cold. So that's the group on the right. Then you've got this group in the middle, which is this prolonged fever without origin. Prolonged, let's say, more than 5 days. Just shout out. I'm going to go a little bit louder to counteract that, but just shout out if you can't hear me at the back. So these from the list before, and this is what you guys said, are the ones still on our list. So pneumonia can have a prolonged fever without focus. Urine, you all said. Viral, Belinda, you said. Maybe blood, but they're usually sick. This, all the weird Mediterranean FAPA syndromes and things like that, and then the malignancy. So there's much less on my list by the time I get there. And this is just in order of commonality? Frequency. So infection's the most common for these prolonged fever without focus. obviously viruses, and you've seen these kids, and sure enough, after 5 days, and you're pushing them back, no antibiotics, no bloods, pushing them back, and then the cough and runny nose develops. Or the classic one that you guys see more than us is roseola. They're really febrile for 5 days, the fever disappears, and on the effervescence, then the rash turns up, and you say, okay, that was roseola. The serious bacterial infections will be next most common with UTI, pneumonia, maybe an ear infection that the kids are too young to tell you about, and maybe a little hidden, is Murilo still here? No. Maybe a little hidden musculoskeletal thing. Kids are they're so hemodynamic that they're much more common to get osteomyelitis. You might see a little kid who ends up with prolonged fever, gets investigated, maybe eventually develops a limp, and they've got a tiny acetabulum osteomyelitis or a little thing in the back or something like that. So that does happen. The inflammatory ones, and then of course neoplastic. So with prolonged fever of unknown origin, are there any GP registrars here? 1. Okay, 2. Okay, fine. I don't want to pick on. Okay, there's too few of you to pick on. So when we start off, we often go down there's this 2-lane thinking, and it's all about what it is. You'll remember what it is to be in med school. The whole game is finding out what this person has. It's a diagnostic game. We love that game. And then as you get more experienced, you end up in the other lane, which is all about risk and safety, and it's more about finding out what this isn't. And this is a conversation we have a lot with our trainees, and I'm sure you guys, if you've got GP registrars, you're having a conversation with them a lot. And we go down the lane at the same time. I work in a world where we're blessed with heaps of staff, so there's 2 of us doing this together at the same time. You guys have to do it just one person in your mind at the same time. So while you're trying to figure out what is the cause of the fever, you're also thinking, well, I really also need to rule out what it's not. Right? That's the same with any presenting complaint. There's a New South Wales health movement, which is WA Health have tried to do, which is a bit clunky. It's called Take 2, Think 2, take 2 minutes to think and then do something about it. It's essentially differential diagnosis, or the surgical sieve. Anyone remember the surgical sieve? Vitamin C. It's just renaming the same thing. It's just stopping and having a think. It's what we did at the very beginning. What causes fever? What could cause fever? All right, a word about malignancy. It's come up a bit. So these guys did a systematic review and meta-analysis and published it only a few years ago. Fever is the 4th most common sign and symptom in children presenting with leukemia. Okay, flip that around. More than half, just over half of new new diagnoses of leukemia in children present with fever as a symptom. So this is my approach to kids with fever with unknown origin for more than 5 days. I rule out leukemia. I rule out serious bacterial infection, and then I've got all the time in the world to figure out what it is. So I start with what it's not. Okay, the febrile guideline, the child with a fever guideline, which is the PCH ED one, Royal Children's Hospital ED is kind of amalgamated, but they're very similar. Starship Hospital over in, it's the kids' hospital, cool name, over in Auckland in New Zealand. All the fever guidelines are pretty similar, whichever one you like to use. But this is it. So fever for more than 5 days. I think somebody said it here, 5 days at the beginning. And yeah, that's why I like to know about 5 days of fever. If you don't want to do bloods, you can get out of 5 days. So what are we now? Saturday morning. So if they come in with a fever that started Tuesday night, that's Tuesday, Wednesday, Thursday, Friday, Saturday, that's 5 days. But actually, if it's Tuesday night, Wednesday night is a full Thursday, right? Wednesday night, Thursday night, Friday night. Tonight is only the end of the 4th day. So it's all about how you sell it. So if I think it's probably viral and I don't want to do bloods, I say, well, yeah, there's 5, but actually I want a full 5 days, 5 times 24 hours. Because that's actually what it means. Anyway. Fine. Any questions on that? Yeah. Yeah. So the question is, would you do a chest X-ray and an MSU and bloods? What would you do? What would you do? Yeah. 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 I do a urine and bloods too. Yeah. Absolutely. Because your bloods, I mean, I'd probably, if they're well and have fever and have had fever for 5 days, if I've got a full blood count with a blood film telling me they don't have blasts, I don't really care what they've got. I've got all the time in the world to figure it out. I know they don't have leukemia, so I can relax. And I know I'm biased because all kids with leukemia, when they're diagnosed, come through PCHED, so I see them all, and you guys might only see one every so often, but that is my bias, and I recognise that. So that's what I want from them. Chest X-ray we can, and we'll come to that a bit later on, but it's absolutely an option. Yeah. Yeah, good question. So how high is the fever we're looking at, and do we document the fever, or is it just on the parent's history? I just say 38. Everyone's got their own, but I just say 38. I need to be a bit boy-brained about it. It's always a binary decision in my world, yes or no. Yeah, so 38 or above. Look, if parents have said they've measured a fever every day for 6 days, well, I've got to believe that. Yeah, I've got 2 choices. There's always 2 choices, right? I've got 2 choices. I believe it or I don't believe it, right? If I do believe it, I can do something about it or not do something about it, right? So if I don't believe it, I don't do something about it, and they have leukemia, that's going to make everybody sad. If I do believe it and do the blood test and they don't have leukemia, everybody's happy. Yeah. Yeah. Oh, preferred laboratory on the really little ones. Yeah. Yeah, so I have 2 that I recommend. PCH-ED, not PCH-ED, PCH Path West, so in-house. That's all the phlebotomists do is take bloods from kids. So they're good at it. And Saturn Pathology, they're out there. Yeah, I don't have any commission from them, but they're brilliant. I was teaching on a course in Northam yesterday, and one of the GPs talked about them. Oh, this is an amazing group, and they come and they've got time, they're trained, they use EMLA, they've got virtual reality goggles. It's really nice, and they go to the home. So, yeah, because otherwise it's very local lab dependent. Yeah. Yeah, so temperature and percentage of dehydration. Yeah, of severity. Yeah. I kind of go, history plays a bit, like how much they've had to eat or drink, how much they've had to drink mainly in the last couple of days, what's their urine output. But if it's a bit easy because they're either flat and they look sick and they're properly dehydrated, or they're running around like a blue-ass fly and they haven't had as much to drink lately. So they're either dehydrated or they're not. If they're dehydrated, in my world, they're either a lot or a little bit. Classical teaching is to use different signs to assess, is it 1%, 3%, 5%. I think newer teaching means that we're all making it up. And so if they're very dehydrated, a little bit dehydrated, and you base it on that. Yeah, so fever, in my mind, I go down a fever pathway and I go down a hydration pathway, and they're not always interlinked. Yeah, okay. Ooh. So would I always send a clean for microscopy? Would I always send for culture even if microscopy was normal? Yeah, and clean catch. Let's talk about clean catch. You mean if the dipstick's normal? Yeah. Depends how it was caught. Sort of answering 2 questions in one there. So clean catch, and we'll talk about it, but clean catch, 25 to 50% contamination rate. Catheter 10%, suprapubic is 1%. You're probably not doing suprapubics in your world. I struggle to convince anyone in my world to do it anymore. Is anyone doing catheter collection urines? Yeah, so you've really got clean catch or bag. Bag urine, you may as well you're just asking to collect bacteria. That's fine. If you want some bacteria, do a bag urine. What I say to families who are doing a clean catch is if you do it well and explain it to them well, and they're not just sitting there with the doodle actually in the pot while they're watching Bluey, that kind of thing, they're actually collecting it well and cleaning them well, then you've got 70-75% chance of collecting a urine that is negative, is clean. If it's negative, you've saved them any other tests. If it's positive and it was on clean catch and the kid's looking okay, now you're stuck whether or not you need to repeat it. All right. So usually I'd follow these kids up and we'd call them if it's done with us, and we'd say, how are they now? If they're still febrile and it did come in with a bacteria, well, then you've probably got to treat them. Yeah. Would I send it off if you had a urinalysis that was negative? Probably not on the older kids. Oh, look, if they're febrile, yes. If they're not febrile and I think it's something else and I was only doing a urine to entertain myself or the parents, then no, I wouldn't send it off. Okay. All right. So that's probably my biggest take-home point. There's a couple, but that's one of the bigger ones. The ones in red are the take-home points. So that's my approach to fever without a focus for more than 5 days. I say mine. This is how most of us will do it. All right. So this is a picture of the algorithm on the RCH ED guideline. Wendy, do we send all the slides around? Yeah, I'm happy. Yeah, it's because on the back page of my slides are all the different references that I've referred to in the different papers, but all the different guidelines that we're talking about here. I'll just zoom in. So this is when to investigate fever in an unknown origin in over 3-month-olds. And you can see the top box is if they're not unwell and there's no obvious focus, if the fever's less than 24 hours, maybe you can just watch and wait. All right? Or you can consider a urine. Gone are the days when, how many of you ended up coming through Princess Margaret Hospital? But yeah. So you'd remember the kids back in the day when I first started training, and you could have fever for a few minutes and they'd all get a urine, and you just have on the back rows between the curtains, everyone would be sitting there with their pants off trying to collect a urine, and they'd be there for hours and hours. We've moved away from that. There's good evidence now, reasonably good evidence now, to say that as long as you can diagnose and treat a UTI in children within about 48 hours, there's no long-term problems. So they've done some DMSA studies and MAG3 renal studies long-term where there was a bit of a delay, and maybe there was a tiny bit of scarring on the scans, but functionally no change to use and ease, creatinine levels and functional urological studies and things like that. So what I say, and I say that to families, mostly I talk to families the way I talk to my juniors, with slightly less banter, but in terms of medical talk, most people have reasonable health literacy these days. And I will say, we don't have to catch this minute. I want to, today's Saturday, they've come in because they had a fever overnight. So that's fine. By the end of Sunday, if this is a UTI, we need to find out and treat it. So you could park yourself in the corner and catch a urine, or you could go home, get a good night's sleep, stick them in front of Bluey tomorrow, and they can catch a urine at home and drop it into your local lab, us, GP, wherever. Yeah. Obviously, the younger kids can different risk profile. Under 3-month-olds with UTI all get treated with IV antibiotics. Neonates with a fever, even if it's a urine source, should get an LP, because about 5 to 10% of neonatal UTIs also have the same bacteria in their CSF. Okay, what does that mean for you? If you've got an under 3-month-old with a fever, they're probably coming to us. The under 3-month-olds with a fever on history, and it's maybe 37.5, and they've got the snots, and the sister's got the snots, and they've been to Woolies or daycare or whatever, and they're looking okay and they're feeding well, maybe they don't have to come to us. But the ones who are febrile, under 3-month-old, and you're not really sure why, they come to us. They're getting bloods, drip, staying overnight. When I say us, I mean ED. I saw it on the list. You guys are from all over. I've worked in many different EDs and PEDS units around Perth and WA. All of them can do this and do this. So you don't have to send them to us. We're very happy to see all of them, but some of them, we know that 50% of kids who come to PCH ED don't live in our catchment. All right, and they love us. That's very kind, but they're welcome to love their local EDs as well. Good. So a little bit of a summary. When to investigate fever of unknown origin. If they're unwell, of course you're investigating them, or you're referring them. If it's longer than five days, you're investigating them. If they're limping, you talked before about, so limping children with a fever will definitely get investigated, because that could be a whole bunch of different things. Murilo touched on a couple of things. It often is septic arthritis, or it can be osteomyelitis. It can be something going on in their back. We've got to check with them about urinary and bowel symptoms, all of that sort of stuff. And then the higher risk groups is the under 3-month-olds, especially neonates, Indigenous, Australian and New Zealanders, and then the and under vaccinated children. Wendy said I had to keep pausing for questions. Yeah. Yeah. Oh, I like that. Good challenge. So you don't have to. There's no evidence behind any of this. You can do whatever. But what I want, so maybe I should rephrase it. I wouldn't want to leave a kid for more than 5 days with a fever. Do I want to do bloods before that? So there's a couple of reasons 5 days turned up in the literature, mostly because everybody's very excited about Kawasaki's, right? So Kawasaki syndrome is that weird autoinflammatory post-viral thing that we're really not sure, but it's they look really sick. They get admitted for intravenous immunoglobulins. They get intravenous steroids. They get a echo because they get coronary artery dilatation, all that sort of stuff. Everybody gets excited about it. If you've got a kid with Kawasaki, and the diagnostic criteria is more than 5 days of fever, they have to have that. That's the part of the Kawasaki. But they also have to have 4 out of the 5 symptoms and signs of Kawasaki. So these aren't the ones I'm worried about because you can see they've got Kawasaki. Kawasaki kids aren't fever without focus. All right, that's one of the reasons 5 days turned up, and I think it's just to make us stop and think. And the other reason is, it's probably just because it's long enough to leave them without finding out that it's possibly leukemia or some kind of occult bacterial infection. And it's certainly too long to leave them without a UTI. You stick with 2 days. I love that. That's fine. Yeah. I love that for whatever. We do 2 days. So by 2 days, I want a, hey? Yeah. Yeah. Are we talking about examination or investigation? Yeah, I would look at them for sure. I mean, I'm a parent of 3 boys, so I do put them in the corner a few extra days than some. But yeah, you'd want to look at them for sure. So this is a question about investigation and treatment. Yeah. Okay. Whew, good. We're back on the same page. I like that. We should chat at lunch. So yes, I definitely want them looked at. And I tell them I want them looked at by you guys, if not us. And I know you guys, it's much harder than it used to be to get into GPs on the same day for all sorts of good reasons and frustrating reasons for you guys. So they can also come back to us. I want them looked at, but they don't need necessarily investigated apart from a urine. Yeah. Would it be good to find their leukemia at the 3rd day instead of the 5th day? Sure. But we know that most of them don't have leukemia. So if you're looking for the leukemia in the 3rd day for all of these kids, you're doing bloods on more kids than you need to. Whereas if you can hold yourself to 5 days, you've probably avoided a whole bunch of unnecessary investigations. But that's a balance, right? Absolutely. Yeah. Yeah, good. We know that and under vaccination is increasing rates in the community. We are in the post-pneumococcal and Hib, the Haemophilus influenza B vaccine era. Do you manage these kids differently? If you have a febrile under or unvaccinated child, let's call it 2 days, versus the one who is vaccinated, do you manage them differently? I don't have do you? Hands up if you do. Hands up if you're more worried about that kid. Yeah. So just good to reflect on that. You don't have to manage them differently, but you could, and you'd absolutely be supported for doing so. Do we investigate and treat this population more? Probably. So we don't have great evidence in Australia of this, but there's some really good American studies. They're often single-centre studies, and there's a link to one at the end. But febrile or under-vaccinated children under the age of 3 are much more likely to get bloods and a script for antibiotics in all places, as in community and hospital, than the kids who are vaccinated. We're not sure about chest X-ray or admission. This group, PEM Currents, that's the first link there. They do a really good podcast. They're an American group, but it was a 20-minute podcast just on fever in under and unvaccinated children. I've put it in the end link as well. So interestingly, this group, Rutman et al. Did a retrospective cohort study quite a few years ago now on occult pneumonia, and there was a question about chest X-rays before, and maybe this will help to answer it. But in the pre-vaccine era, And we'll talk about that and what that means now. But in the pre-vaccine era, kids under 3 years old with a fever over 39 and a white cell count over 20 with no signs of pneumonia had a 20 to 40% chance of having lobar pneumonia on an x-ray. That annoys the shit out of me because like we're doing all this good work, but actually we just got to guess. What does that mean in the and under-vaccinated group in a majority vaccinated population? So we can answer that question a bit later, but still 10% of them will have. So if you've got a vaccinated kid in your rooms on Monday with fever and a high white cell count, there's still a 10% chance of them having pneumonia, even if you can't hear anything, and that's a normal. How annoying. So anyway, just a thought. So you might do an x-ray. But I'd be much more likely to do investigations on an under or unvaccinated child, and we could talk for a very long time about judgment and things, but you know, if you can sift through all of that, it's all about risk, right? So we just treat that child, and we try not to do it. We're not doing a blood test because they chose not to vaccinate and it's punitive. It might feel a little bit good if you want to do it that way, and you keep that to yourself, but you're doing a blood test because you think they need it. All right, that was just in case anyone asked me about the vaccination schedule because I don't remember it. Let's talk about Indigenous patients. These are all the Aboriginal medical services around the state. There's so many more than I thought. It's really cool. So Indigenous patients, so Aboriginal, Torres Strait Islander and Maori patients have a much higher risk of serious bacterial infection. There's a whole bunch of reasons, both social and scientific, around that, but suffice to say that they do. Certainly if they're living in more rural and remote areas, certainly if they're if they're a lower socioeconomic status, or there's a few more social determinants of health going against them. Rheumatic fever in Indigenous kids, we have to remember that. And so as long as you just remember to Google your Jones criteria or the diagnostic criteria of rheumatic fever, the Australian Heart website, what's that one called? Heart Foundation website, I think, has got a beautiful, like a one-page summary on investigating and managing kids and adults with rheumatic fever. Probably we're getting some evidence that says that probably Indigenous kids who live in higher socioeconomic areas and certainly around the cities probably have much less risk of rheumatic fever than their rural and remote counterparts, and the ones living in the city with a lower socioeconomic status. It's probably more about their cumulative exposure to strep and staph and things like that. So yeah, absolutely lower threshold for antibiotics. All right. So we've covered that. We're going to talk about UTI, chest pneumonias and ears. Kind of covered it a bit. And then we'll talk quickly about when to refer and how to safety net them. But we're going well for time, so if there's any questions or comments at this point. Yeah, 2 here. Yeah. Of what one? Yeah, burning. Yeah. Yep. Yeah, good. Yeah, I also worry a bit more about 40 for some reason. I'm still not sure why. Yeah. Yeah. So yes, good. So the question was about, do you worry more if the fever is over 40? That was a reasonable summary. Yeah. You can, right? Yeah. Look, in my world, there's always two choices and everything's negotiable. And because there's not heaps of evidence, it doesn't matter. So as long as we're thinking about risk, and risk is so subjective. There's a little bit of science, but so subjective. If you or the kid or the parent are worried about that kid, you do something about it. You know, how worried are we? You worried they've got leukemia? Oh shit, no, I just want a chest x-ray. Oh, fine, great, we can do a chest x-ray. Or maybe they are really worried they've got leukemia. Fine, we'll do a quick blood test. Yeah, so do you need to treat them differently for over 40 degrees? Probably not. Do you need to recognise that everybody in the room is going to be more worried if they're more than 40? Yeah, because it's fun to recognise and it's quite nice to shine a light on that. But do you need to do something differently? Not necessarily. No, not at all. So unfortunately, sepsis, the average fever it's actually lower than you think for sepsis because they're so sick that, they're at the other end of the bell curve. The average CRP over the last 3 years of kids who were admitted to ICU at PCH with septic shock is mid-30s. Far out, right? Like we're all just dancing around the edges, crossing our fingers that it's not us on the shift. So how you keep them safe is time. Time, and you've probably said this yourselves, time is the best test for sick kids. And if you don't have time to do that in your practices, which of course you don't unless you've got one of those where you can pop in the weight room for a few hours and it was a bit awkward, I get it. You send them to us. I love admitting kids to do nothing for. Pediatricians hate me for it, but that's what their job is, even though they've forgotten it. It used to just be, you stick a kid on the ward next to a SATS probe and a nurse who's been doing it for 30 years, and they'll call you if something changes. And if they don't call you, you send them home in the morning. That's old school pediatrics. You will get that more likely at the peripheral hospitals because they've got more beds usually, but that's all they need. So, but if you're worried, you do a blood test, you do a chest X-ray, or you get an opinion from us. You'll never get too much grief for that. Yeah, you'll get grief if you don't, and there's something serious going on. Yeah. 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 Yeah, how much weight do you put on a CRP? So one of my favourite games is when the trainees will come and they say, I'm going to do a CRP because this kid's febrile, I'm worried. I say, great. At what number are you going to send them home? And they squirm and they're awkward and I don't really care. They just got to come up with a number. Because the evidence is, that's 10 minutes, thank you, Andy. There's no evidence. CRP, procalcitonin, ESR, white cell counts. They've done studies and studies and studies and studies, and unfortunately, it all comes down to Gestalt. It just comes down to your gut feeling, your concern, and your pattern recognition. Is this one who's looking there's just something about this one that bothers me. And it might be because you saw another one in the news yesterday, and so you're a little bit off kilter. Fine. Since 2021, PCH ED are doing way more blood tests than we used to, because there was a kid who died in our ED from sepsis. Fine, we recalibrated and eventually we'll go back to doing less tests. That's okay, we know that. You can't judge us, we don't care. All right, so it depends what else is going on in your world and the kids' world. Yeah, but if you're like, no, I think this one's fine and the CRP's low enough, fine, you've got time. That's where it comes to your safety netting. Yeah, I know, the fella behind you is just, yeah, I know, really hard. And if you're going home, and you've probably been told this as well, but if you go home and there's a chance you're going to think about that kid tonight, send them to ED and we'll admit them, right? Or we'll stick them in the corner for a few hours. That's the other thing we do, and that is why we send home 60 to 70 kids with a fever every day, because they've sat in the waiting room for a few hours, usually before they've seen one of the docs. They've had 3 nursing assessments, 3 full set of vital signs. They've had Panadol, Nurofen. We've watched them eat half a tub of yogurt and spread the rest on the chair, and we're happy that they can go home. You've got 15 minutes with them, right? So you just send them to us. Are we picking up more? Well, interestingly, we're not picking up more ALLs, so acute lymphoblastic leukemias and neoplasms, because those ones tend to end up getting bloods anyway. What we're probably doing is picking up more viruses with low white cell counts and a CRP that's 15. So yeah, we're doing more tests, but we're not finding necessarily the sicker ones more, because they're the ones which sort of come out of just keeping them on the ward longer. Yeah. Cool, all right. So let's finish this off. Blah, blah, blah. So we'll just talk about this very quickly. Is Phil Sale still in the room? Oh, okay. ENT talking about this. Luckily, there's only one slide. So otitis media, 48 hours with a fever and a bulging red eardrum. It is an indication to treat with amoxicillin. 80% of them or so will still get better by themselves without the amoxicillin. But at that point, sure, why not? Sometimes you'll give a script and say, look, I've seen your red eardrum. You've had a fever for a day. If by tomorrow or the next day it's still hot, then do the script. That makes all of us feel better. The evidence shows that they're going to feel it anyway. It doesn't matter. We still feel better, and that's okay. So that's and also you've made sure that it's not mastoiditis, or there's also a pneumonia, or because kids get red ears when they are when they've got a fever and upper respiratory tract infection. They usually don't have unilateral bulging eardrum on one side. That would be more in keeping with otitis media. And there's some good guidelines around that with nice flowcharts. Pneumonia we've talked about. So now here's an interesting question. If you've got a kid, 5 years old, fever, 3 days, they're coughing, they've got asymmetry on your auscultation. On a show of hands, who would do bloods? I'm going to put my hand up each time, even though I don't necessarily would, but no? Okay. Who would do a chest x-ray? Oh. Who would do a chest x-ray? Yeah. And who would treat anyway? Yeah, fine. Cool. Same. You can do a chest x-ray. I love finding a pneumonia. Look, I mean, if you got that, you're like, yes, found one, right? You know, we've got a pneumonia. But you're going to treat either way, so maybe you can skip the x-ray. We've done a recent audit in PCHED, I'll come in a sec, showing that we do way more x-rays than we need to. We have location bias. People are expecting x-rays and bloods, maybe, or maybe we think they are, so we do a lot more x-rays than we need to. But if you've got fever, cough for a few days, asymmetric auscultation, antibiotics, they've got pneumonia. Good old-fashioned diagnosis. Yeah. Yeah, absolutely. Yeah, absolutely. Yeah, yeah. Agreed. Yeah, let me summarize it for these guys. So if they're well, if they're not particularly, if they're not drastically unwell and you're sending them to ED, these kind of kids may be mucus plugging and they have a cough and actually that side clears up. Also, if there's a viral-induced wheezing or asthmatic or bronchoconstrictive process, sometimes that happens at different rates and they tend to close down and open up at different rates. So yeah, you're absolutely right. If you can get to see them the next day and they're not too unwell, you could hold off. Yeah. Okay, good. This is what we talked about before. So if they've got no signs on the chest, but they've got a high fever and you've done bloods because you didn't find anything on the chest, if they've got a high white cell count or a CRP of, I don't know, 50, 100, more than 300, we can definitely agree on. But yeah, 50 to 100 is usually what we say. Then you'll call the family and you'll say, how are they? This is the day or two later. If they're no longer febrile, well, that's fine. You've saved the need and they're running around happily. You can say to the parents, great, safety net them. If they get sick in the next couple of days, come back or go to ED, but they don't need antibiotics. But if they're still febrile and you've found that they've got blood tests which are off, that's when they need to come to you or they need to come to us. So that's one way of doing it. Yep. I've talked about that. Yep, and there's the CHAMP guidelines, so the Children's Antimicrobial Management Policy or Protocol or something. That's the antibiotic guidelines that PCH has. It's really helpful. So start with amoxicillin. If you still believe in, we do still believe in mycoplasma, then after 48 hours, if they've come up with mycoplasma on a swab and you've tried amoxicillin, then you can add in a macrolide. Okay, UTIs, we've actually kind of talked a lot about this. Yeah, it came up before. What I did want to say is we get a lot of children being sent to us or self-referred with query UTI. Now, yeah, some of them don't have a fever, but just remember if they don't have a fever and the urine is bland, you've got to think about other things. And a lot of them are rare or at least, you don't see so often, but you just have to think about them. Vulvovaginitis in little girls, balanitis in little boys, worms in both groups, constipation, and then of course you're always in the back of their mind thinking about non-accidental injury and child sexual abuse. But if they're afebrile and the urine's okay, think about some of those other traps. Because often we'll find them and you say, okay, well that's fine, we'll treat them and go home. Good, okay. So we've talked about those three things. Last two slides. Oh, we've still got 5 minutes. Right. Good. So obviously, I was asked to talk about sepsis as well, but I think in a GP context, if you're worried about sepsis, you're either sticking them straight in the car or you're calling 000. So that's fairly easy management from that point of view. If you need time and observation, which you just can't do where you are, fine. You know, some of you work up in Dalwallinu and Harvey, and some of you might have to just hang out with them in the clinic for a few hours, but otherwise you can send them to us. If they need IV antibiotics and admission, of course, they're coming to us. And don't forget, you've got phone advice. So there's a consultant in charge between 8 a.m. and midnight, and in winter usually even a bit later, going through Switch, and you can come directly through to us. A lot of GPs do, and they ask us for a bit of advice. It's really helpful. We have a chat, and then you either send them in or you don't, and make a plan or a backup plan. And then overnight you've got a registrar, although hopefully not too many of you are working overnight. The safety netting is about what you're saying and what we're saying when we send them home. There's a fever handout that we give them that you've got access to that I've put at the bottom of this slide. So if you send them home, if they've had fever for less than 5 days and they appear well and they're hydrating themselves, we talked about hydration before, and you do want another review if they're still febrile after 5 days, and at that point you'd consider chest x-ray and bloods. And I say that to the family. It keeps me and my colleagues to account. I say, if you come back, it's been 5 days, we're going to do x-ray and bloods, so that when they come back in, or at least bloods, when they come back in, they say that to my colleagues and they say, hey, you said you were going to do bloods. Sort of forces their hand a little bit. We tell them to present ED if they deteriorate. We can give them advice on antipyretics, which is in the handout. There are some not odd, that's a bit judgy, isn't it? There are some non-evidence-based practices which parents do. You can always ask them to talk about those for you, so you can say probably none of them help, and some of them can make the kid feel a bit worse. And then you give them this fever handout. So, we've talked about why there is a lot of stress around fever, when you can be worried, when you've got license to be worried, when to investigate, when to refer. We've talked about safety netting, and then specifically we've just drilled down on some of those fever without origin, prolonged fever, somewhere between 2 and 5 days, UTI, pneumonia, and otitis media. This is just some resources on the back of the slides. These are the CHAMP guidelines, which you can find. This monograph here is all the different drug doses and everything as per the PCH guidelines. And the reason it's nice for some of you who work in the country is these ones are driven by the bacteria resistance profiles of Western Australia. So it's for all parts of WA, slightly different to Queensland and Northern Territory, and so that's good. Okay, so just that dual lang thinking, I think it's with all medicine probably, although I don't treat adults anymore, but it's always what could this be, and what am I making sure it's not? Both lanes at the same time. So always consider the diagnoses not to miss, and bloods for prolonged fever without a fever of unknown origin, just looking for those bacterial hidden things, and for acute leukemia. Use the guidelines and always be happy to phone a friend. They're all the things that you can have a look through if you want at the end. Thank you. On time.
Any further questions from Paul? For Paul, and we'll run around and try and get the microphones to you.
Just one comment. I noticed a little study that came out recently about how important it is to listen to parents, and that parents are often right. Did they really need to study on that? Did they really need to study that we should listen to parents?
Did they really need to listen
study that we should listen to parents and their concerns?
Oh, I love that question. That's probably a statement more than a question.
It's more of a statement.
Yeah.
I don't know. I just say, if you're worried, I'm worried, please come back.
Yeah. Parents, there's a balance, isn't there? Parents know their kids better than us. Yeah, there's a pendulum that swings, right? And that's great, but the way the government, you've caught me, I need a beer for this conversation. The way the government runs us a little bit is a bit too much on that side, I think. Parents know their kids the best, but we're the ones with a medical degree, so there's that balance, isn't there? And sometimes we get some we've had some really nasty situations where we're now putting parents in timeout in the waiting room and stuff. It's just because that's probably gone a bit far. So yes, of course we have to listen to the family. And there is good evidence to show that mostly we do. The ones we find out about where we didn't are the ones where bad things happen and it hits the news. But the ones which don't hit the news, we've all listened, and there's heaps of compliments that come in for hospitals, EDs, GPs, where they've had lovely communication and lovely listened to. Yeah. But yes, good question. I agree. Yeah, we've got to listen to families. That was a long hour. Thank you for being so patient.
I think there's one last question.
Oh, one more, sorry.
So I do have some parents who refuse to give antipyretics because they say it masks their temperature. What advice would you give these parents?
Yeah, I love that. I actually was wrestling with a family recently who didn't vaccinate, didn't believe in antipyretics, and didn't want a drip or a nasogastric, and the kid was febrile and dehydrated. It was a real challenge. What do I say to people who don't want to give antipyretics to mask the fever? I usually start with, in my world, there's always two choices and everything's negotiable. And I usually say the other thing, which I've already said to you, is the hardest decisions in life are the ones which won't make a difference in the end. And then I'll say, let's talk about most families, right? Not your family, I'm not talking about yours at all. Let's talk about most families. Most families will do it for these reasons. Some families, not your family, some families don't do it for these reasons. Let me tell you why it doesn't matter to me. Let me tell you what happens with the two choices. And I always bring them back to a two choices thing. So if you give it and it masks it, well, it won't, but if it masks it, we can hang out for as long as we want. Now, that's our advantage that you don't have. All right, so I'll say, let's give Panadol, Nurofen, make the kid feel better. If it masks some horrible disease, hang out for 4 hours. I'll put you in my obs ward and we'll see together what happens. All right? And if you don't give it, the kid's going to look miserable. Eventually, you're going to be a bit bored of seeing them looking miserable, and we'll talk again and do, so I'm trying to give, not care less, but kind of give less of a shit for the things which probably don't matter in the end and save it for the ones which do. So if they don't want to, that's fine. But yeah, I say, it's kind of like, yeah, sorry, yeah. Yep. Yep. Yeah, that's absolutely the ones who really want to treat it, and we know they do, right? Yep. Yeah, look, every now and again we'll see a kid who's a little bit Panadol toxic from too many doses, honestly, and we've got to stick them on some N-acetylcholine and things, but it's quite rare because generally if they're sick enough to have had that much Panadol for so many days, they've turned up for a blood test or something, and so you figure that out. But a similar sort of conversation, so you don't need to. So I say we treat for fever and misery, right? Whatever that misery looks like. You don't need to treat for fever alone. And then if they really want to, again, but you can give them permission not to. Some parents, I think, would like permission not to. Yeah.
All right, fantastic, Paul.
Cool.
Thank you so much.
Just a little something. Thank you.
All right, just before you all head to lunch, just a quick little bit of messaging from the ED up at Joondalup, which obviously I'm more associated with as well. They reached out to me just to let everybody know that they're actually done a bit of a loop on really loving us calling when we're sending patients in. I'm going to give you their deck phone number, which they want us to call. I tested it out the other day, and they were very friendly and very lovely that I phoned, unlike perhaps that's like, just send a letter. Yeah, that's why I'm going to give you the direct number, Gina, and you can call them, because that has historically perhaps been a problem. But if you call 9400 9066, it's in the recent GP Connect newsletter as well. They like it because they can help to triage the patients when they arrive if we've given them some valuable information. It also helps, like if it is a service that isn't offered at that particular hour at Joondalup, they can let us know. So they can give us some phone advice, perhaps about something we could do beforehand. So they're really keen to hear from us. So just keep that in mind as well. Yes. Sorry, yes. Yeah, you'd like, Paul? Oh, here.
Yeah, thanks. We would love you, if you're going to send them to us, we'd love you to call us. For a few reasons. A, give us a heads up. B, there may be some things that you can do without needing them to come to us. And we're seeing 300 kids a day. We don't care if we see one more or one less. It's more about the kid. If they don't have to come, that's good for them. Or there might be a closer ED to them. And I'm happy to give Belinda that 24 number is 64560010, and you're going to write it down right now, 64560010. But Belinda can circulate that, and that's the doctor in charge of ED 24/7. But yeah, we always love to know if they're coming. We put them on our specs, and then the triage knows what to do when they arrive. Yeah.
Thanks, Paul. So if you didn't get the Joondalup one, it's 9400 9066, and that is the ED consultant phone. You're not going to speak to someone else to be put through to save you time. Okay. Anyhow, we've made it through to lunchtime, so please feel free to go out and have some lunch, and we'll let you know when to come back in again. Thanks, everyone.